11, I had menstrual cycles that were extremely painful and have excessive bleeding. I would have menstrual cycles for weeks or months at a time, but yet the next time I could have no menstrual cycle for 6 months. After the birth of my youngest son, William, I had a difficult time healing, and my bladder was never the same. I could not sneeze, cough, or anything without leaking. After my children were born, the extreme difficult menstrual cycles continued. I saw several doctors. 7 years ago, I was at my wit's end, and one doctor suggested having a full hysterectomy and tacking my bladder up and the installing of a bladder mesh or sling to correct my bladder problems. The menstrual pain was gone, but then shortly afterwards, there was a new pain that was deeper and lower associated with around my bladder, like I'm being stabbed, but from the inside. Now, I have trouble even standing up from a chair. I'll be walking, and next thing you know, I'll scream out and just collapse on the floor because the stabbing pains get so bad. The only way I know how to describe it is suicidal pain. It's so bad now that you don't care if you live or die. I want so bad this mesh just to be removed. I want my life back. I want the pain to quit.
One actually had a hard time finding the right surgeon to remove the mesh, but her search finally ended when she found our good friends, Dr. Robert Moore and Dr. John Miklos.
On examinations, we noted 2 areas of pain. The area of the sling, i.e. the mesh, and the area of the hysterectomy. We can relieve the pain of the mesh, we believe, by removing the mesh, but we will also explore the area of the top of the vagina where she had her hysterectomy. Putting a self-retaining retractor in place just allows us to expose the area that needs to be evaluated. We inject the area with Novocaine to create a local numbing effect so we can begin our dissection.
We have to be careful because there's a lot of tissue ingrowth into the mesh. Sometimes if it's placed real deep, it can be very close to the bladder, close to the urethra, and that's why many surgeons are not comfortable with removing.
We have about 3/4 of the sling dissected out. I'm going to take it out as far laterally as possible to the pelvic sidewall where it inserts into her muscle. Now, I've just resected the mesh. We have removed 7.5 centimeters.
They're actually injecting a blue dye into the patient's vein now that will go through her kidneys and down into the bladder so that we can make sure that the kidneys are working, that the tubes haven't been blocked, that there's no injury to the bladder or the urethra. You can see that blue dye jetting out, so that's coming from the kidney. So we know that the tube from the kidney down into the bladder is still working and not blocked. Now that Dr. Miklos has removed the mesh from below, what we're doing now is coming above abdominally, and what we want to do is assess any problems that we may be able to see down in the pelvis and the abdomen. So here we are taking a look at her intestines. She's got a few adhesions down here. They're pretty mild. We'll take those down. Here's the pelvis. This is going to be the rectum down here. Got quite a bit of pain in this region here. She's got good vaginal length. But we really feel that everything went really well during the surgery, and hopefully she has significant relief of the pain that she was suffering.
Dr. Miklos and Dr. Moore, join us again. A pleasure having you back on the show. And when does mesh become a problem?
The mesh becomes a problem when the patient tells you it's a problem. And the number one problem we just noted in our recent study in over 400 patients since 2011 is pain.
And docs, can you do a little explanation as to what the mesh is designed to do, why it was even put in there in the first place in the average patient?
Sure. It's designed to give the bladder support in women that may have had a very large prolapse, a recurrent prolapse. Those are the patients that their own tissue doesn't work very well. And so it was designed to try to give higher cure rates. And it works very well in many, many women. It's attached to the pelvic sidewall muscles. It supports the whole bladder. However, if it heals too tight or contracts, it can pull on some of these muscles and cause pain or bladder obstruction or other symptoms. And the problem is that these were a new set of complications that we weren't used to seeing. And so very few people knew how to treat them. And so many patients were just pushed off and saying, there's nothing that can be done, or just go to physical therapy, or it's all in your head.
And Wanda couldn't be here with us today, but she is on the phone. And the most important thing we want to ask Wanda is, how are you feeling?
I am feeling great. This is the first time in over 7 years that I can say that I'm without pain.
You're feeling this way, and how far out of the surgery are you?
3 days.
That's pretty remarkable. Dr. Miklos, Dr. Moore, thanks so much for being with us once again. There's more coming up after the break.